In part 3, we're going to start with talking about the serotonin antagonist, and that would be our ondansetron and granisetron. I'm not sure I'm saying, because I'm so used to saying Zofran, but you need to be familiar with the generic names as well, because that's where NCLEX is going, using only generics name. So ondansetron and granisetron. These are, I would say, second, third generation. These two medications were developed for chemotherapy-induced nausea and vomiting, because, like our Phenergan, our Compazine, those two, helped control it, but were not as effective. So both of these can be given PO or IV. These block the effect of serotonin at 5-HT3 receptor sites. They're selective antagonists, and these are located in the vagal nerve terminals. That's where some of the triggers for vomiting, or that's where vomiting starts a lot of times. The serotonin antagonists were initially indicated for treatment of the chemotherapy-induced nausea and vomiting. And this classification drug really has improved the quality of life for patients receiving the highly emetogenic chemotherapy. But they are now, as you will know, they were so successful for those that they are now have spilled out and are used probably more often than the phenothiazines are now, because they have spilled out and they have been so effective that they have taken over some of the use and don't have quite the severity of side effects that the phenothiazines might have. Okay, come on. There we go. Moderate, their side effects, you can get moderate to mild to moderate headaches when these have been administered. Of course, the dizziness can occur, constipation. Some people do get diarrhea from it, so it can go either way. It does, instead of the drowsiness, though, they do get a feeling of malaise or fatigue. It can affect the liver enzymes, and there's a possibility of those extrapyramidal effects occurring. Now, if you go back to the pharmaceutical action, it affects serotonin. There has to be that homeostasis, that balance between dopamine and serotonin. Both of those have to do with transmission, neurotransmitters. They are neurotransmitters. Unlike with the dopamine, it's going to cause tremors. But again, the serotonin is the same thing. Serotonin and dopamine work together to stimulate nerve conduction and put brakes on it. So it makes sense that those extrapyramidal effects might occur with the serotonin antiemetics. Anti-em is a mnemonic that you can use to help remember the facts about the serotonin antagonist. Their action is that it blocks serotonin at those 5-HT3 receptor sites. They are a selective antagonist. They usually are used for nausea and vomiting from chemotherapy or radiation to prevent it. And of course, we want to take them before chemotherapy. The I in anti-em is that it does have interactions with other drugs that can affect the AST and LAT, and those are drugs that measure not liver function, but if there's been any damage or if there's any decrease of function in the liver. The extrapyramidal effects are undesirable, and you must report them for the E, and we're going to monitor their AST and ALT during treatment, which would be their liver function. There's not enough human data for use in pregnancy. Remember, I said this is like a second or third generation antiemetic. So it was developed past the point that ethically you can conduct experiments on women who are pregnant. It has been used in hyperemesis gravidarum, which is someone who experiences nausea and vomiting throughout their whole pregnancy, and it does affect weight gain. And it has been used without adverse effects on the fetus, but generally it started after 12 weeks, maybe at the minimum 10 weeks, but it's not started until they're relatively sure that initial fetal development has occurred, that development that would affect the heart, the intestines, or anything congenitally. We're going to use with caution in women who are breastfeeding, and we want to use in caution with patients with severe cardiac dysfunction because it can cause some ECG changes or electrocardiogram changes. It can interact with certain drugs to prolong the cardiac conduction intervals, meaning that it would affect heart rhythm. And we need to use caution in patients that are taking diuretics. Now, Zofran is one of those drugs that they're look-alike, sound-alike, and so it has been confused with Zosyn, which is piperacillin tazobactam. And this is one of the reasons they want to go to generic drugs, although some of the generic drugs look very much alike too. So the ondansetron, and Zosyn, the Zofran and Zosyn could be mistaken. The Zosyn that's a pretty, that antibiotic is one that is generally used if a person has been on a lot of antibiotics, has been hospitalized or in a facility, and they have an infection that could possibly be resistant to other antibiotics. So it's a pretty powerful antibiotic. So you can see why we don't want to confuse the Zofran and the Zosyn. We want to assess for nausea and vomiting 30 to 60 minutes before and 60 minutes after administration. We want to assess for abdominal distension and bowel sounds before administering and during treatment because, again, it can affect peristalsis. We want to monitor for the extrapyramidal effects. We're going to monitor liver function test, and it should be administered prior to chemotherapy, at least 30 to 60 minutes prior to. We want to instruct our patient to take the ondansetron as directed. Again, we want them to take it 30-60 minutes prior to chemotherapy, and we want them to notify the healthcare provider immediately if they have involuntary movement of the eyes, face, or limbs. We want them to increase fluids and fiber to prevent constipation and avoid activities that require alertness. Now, these medications do not cause the amount of drowsiness that the other ones, the phenothiazines, the anticholinergic antihistamine, and the serotonin ones. we don't. They don't cause the same degree of drowsiness, but they can cause some drowsiness. And we want them to avoid alcohol, just as we did with all of the other antiemetic classifications that we've been studying. We'll move on to metoclopramide. Metoclopramide, or Reglan. It can be given POIM or IV. Reglan works a little bit differently because it's used to treat nausea and vomiting that's caused by GI problems, like diabetic gastric stasis or post-surgical gastric stasis or gastroesophageal reflux associated with nausea. Gastric stasis is actually delayed gastric emptying. Anything that slows down peristalsis and keeps the stomach from emptying quickly. Now, if the stomach is not emptying, then you can see how that would cause nausea and vomiting because it just hangs out there and the patient bends over, the patient does something that jostles that food around, they would be more likely to throw it up. It enhances motility and gastric emptying by increasing the duration and the extent of esophageal contractions. So it's going to speed up peristalsis to help empty it. It also increases the resting time of the lower esophageal sphincter, the LES, and gastric contractions of peristalsis of the duodenum and the jejunum. So it's going to increase those peristalsis to help move things out. It's used also in the prevention and treatment of chemotherapy-induced nausea and vomiting. Because chemotherapy and the action of chemotherapy on the body can delay peristalsis or can slow down peristalsis. It is, and it is both a dopamine and serotonin inhibitor in the chemoreceptor trigger zone for vomiting in the central nervous system. So it's got kind of a twofold purpose. It kind of speeds up and stimulates peristalsis, but then at the same time, it does have some inhibition on dopamine and serotonin. Now, this one is particularly risky for extrapyramidal side effects, and particularly Parkinsonian, the mask-like face, the drooling, the tremor, the cogwheel rigidity, that pill rolling motion, gait abnormalities, and difficulty swallowing. And you're going to know with Reglan if this is a problem because it will usually present itself in 24 to 48 hours of administration or initiating administration. This can cause drowsiness, diarrhea, restlessness, dry mouth. It can drop the blood pressure. Again, those extrapyramidal side effects. And then we're going to add tardive dyskinesia to this. Tardive dyskinesia is neurological symptoms, it's involuntary face movements and jaw movements. It's grimacing. Now, it's not just the patient grimaces. It's like repetitive grimacing, eye blinking. And this is like repetitive, not the usual eye blinking. The tongue jutting out, it's puckering and pursing of lips, or lip smacking, jerking of arms and legs, and the patient will say, I cannot stop it. This is involuntary. It's not me doing this on purpose. So that would be a description of tardive dyskinesia. High doses of metoclopramide is defined as 2 milligrams per kilogram per dose. So that would be considered a high dose. And usually that high dose would be for people that has the chemotherapy-induced nausea. And other things are not working or you're using it with other things. We know that 25% of adults ages 18 to 30 do experience the dystonic reactions, those extrapyramidal symptoms, and the tardive dyskinesia after receiving high dose. So the thing is to keep that dosage as low as you can to do what it needs to do. That's the takeaway from that. The extrapyramidal symptoms usually occur within 24 to 48 hours, but they will subside within 24 hours of discontinuation. And also, just like with the phenothiazines, the antidote for them is diphenhydramine or Benadryl, 25 to 50 milligrams. It can be IV or orally. And I know that we used to do like what we call a Reglan pump. We would give Reglan sub-Q to hyperemesis patients. It worked fairly well. We'd teach them to do it sort of like an insulin pump to do the Reglan. And that's a low dose. That would be a low dose. And it is after 12 weeks of pregnancy that was done. The fetus was past that developmental point in which the medication could have caused congenital anomalies. So it was generally after 12 weeks. And we would always tell them to keep Benadryl on hand in case that happened. So again, this is more suspect for causing the extrapyramidal symptoms than the other antiemetics. It can interact with the monoamine oxidase inhibitors. These are generally the antipsychotic or psychiatric medications. And as we proceed through this pharmacology course, you want to see that a lot of medications are going to interact with the monoamine oxidase inhibitors, the MOI inhibitors. It will increase sedation with alcohol and with other CNS depressants. It is the metoclopramide antagonists include anticholinergics and narcotics. So that means that they should not be taken concomitantly with antibiotics with the antiemetics that are classified as anticholinergic. So that group that are classified as those anticholinergic antihistamine, which is like the meclizine, the dramamine, they should not be given if a patient is getting Reglan. You should not get them together. And narcotics. They diminish the ability to facilitate gastric emptying, and they accelerate the intestinal absorption of drugs and foods if they're given with those medications. We want to avoid that. And our nursing considerations, we want to monitor for CNS depression, and like I said before, we need to have a baseline for that patient. We're going to monitor for those extrapyramidal symptoms and tardive dyskinesia. We want to assess bowel sounds prior to and during treatment because it can affect the bowels. We want to hear good bowel sounds. We're going to assess liver function test, and we want to monitor for signs of dehydration. We want to instruct the client that the drug can cause drowsiness. Again, just like with all of these others, every one of them, we want them to avoid driving or other activities that require alertness. We don't want them to use alcohol with it. We want them to avoid other CNS depressants and avoid medications that have anticholinergic effects. Now, there are other medications other than the antiemetics. There's a whole group of them. So we want to make sure that we are telling the patient to read labels to make sure it's none of those other medications. We want to avoid opioids. They would be considered narcotics that we just talked about. And we want them to report any involuntary movement of the eyes, limbs, or any other undesirable effects to their provider of care. And here's a mnemonic that can help you remember the points about metoclopramide. Is they do control nausea and vomiting, and the N for nausea, we're going to use the mnemonic nausea. So the N for nausea, they do control nausea and vomiting. They accelerate gastric emptying. They have the U in nausea, undesirable effects, the tardive dyskinesia and drowsiness. The S in nausea, we want to stay away from anticholinergics and opioids, no alcohol or CNS depressants. The E in nausea, we want to educate about no driving until mental alertness is determined. And A, nausea, assess for central nervous system depression. And this need a bag when you gag, don't fill a bed in, ask for Reglan. Again, sometimes I know this is so commonly given Finnegan, but being in El Salvador on a mission trip, half the time I would have nausea and vomiting because even though I was very careful with the water, for whatever reason, it's a different environment there. And so the first time I took Finnegan, I kept nausea and vomiting. I mean, it went away, and I finished the mission trip. But then after that, our doctor there that oversaw everything said, let's do Reglan, and that worked much better. So you just have to leave it up to the healthcare provider. Again, the Reglan has a lot more side effects and possible more serious side effects than some of the other antiemetics, but it is a valuable drug. You will see that it is going to be repeated when we talk about peptic ulcers. So our corticosteroids, they're really, the mechanism for them, for nausea and vomiting, is really unknown, but they are not used on their own. They are usually used in conjunction with other medications, other antiemetics, and particularly with the chemotherapy induced. As a matter of fact, that's how they are used. They are used in conjunction with other antiemetics for the chemotherapy-induced nausea and vomiting. We don't know for sure why they work, but they do inhibit prostaglandin, and you will learn when we do GERDs and when we talk about other stuff that prostaglandins have an effect for lots of different processes in our body. They are particularly helpful for nausea and vomiting that's associated with increased intracranial pressure because they have the anti-inflammatory effect and decreased swelling. The corticosteroids, again, are usually used with other agents. I know that a lot of the kids that I took care of with leukemia would get rounds of corticosteroids, but mainly it was to help with their appetite. And again, it's that inflammatory response of their body to the chemotherapy and the destruction of the cells that needed to be destroyed due to the cancer. Our adverse effects, there are many toxicities with corticosteroids. We'll talk a lot about them when we get to them in this pharmacology course. People have mood swings with it, so they get very irritable on the corticosteroids. They can experience depression and anxiety. Headache is a common side effect, restlessness, insomnia. It does increase their blood glucose levels. It can increase their blood pressure. It can slow wound healing, and long-term effects, it does decrease immunity. There are really some serious consequences to long-term corticosteroid use. So again, these are used very short-term with taper-down doses when we're talking about use with antiemetics, but I will mention their long-term consequences. They do mask the symptoms of infection because they are anti-inflammatory, and inflammation is important, or the inflammatory response, the cascade of things that happen with inflammation are very important when we are trying to fight infection. They do cause muscle wasting. They can affect our adrenal cortical system, which is our endocrine system, and that adrenal cortical insufficiency has a lot of detrimental side effects. So again, we will talk about that later. They can lead to fluid and electrolyte imbalances, cataract formation. They do prevent the calcium from being utilized correctly, so they can cause osteoporosis, and they can lead to gastrointestinal bleeding. Our interactions, barbiturates, pentobarbital, Nembutal, secobarbital, Seconal, those are sleep measures, and we've talked about that some with all of these. Both of these are for sleep, and then phenobarbital is a barbiturate, which is used as an anti-seizure medication. So it decreases the effects of these medications. Rifampin, which is an antibiotic that's specific for tuberculosis, it affects that and the effectiveness of the rifampin. And ephedrine, which treats bronchospasm, of course related to asthma or severe allergic reactions, it decreases the effect of that as well. We want to use with caution and monitor potassium levels closely when used with potassium wasting diuretics. And the potassium wasting diuretics would be the furosemide, which is Lasix, or hydrochlorothiazide, HTZ. Of course, we're going to monitor our vital signs, especially our blood pressure. So again, we need to make sure we have good baseline blood pressure. We're going to monitor our weight. because if we are retaining fluid, which it can cause you to retain fluid, which puts extra load on the heart, and if you have any cardiovascular issue, that is problematic. So the only way to really tell if you are retaining fluid is to monitor the weight. Yes, you say intake and output, but you can have a good intake and output and still be retaining fluid. We're going to monitor electrolytes, which would be your sodium, your potassium, your magnesium, your chloride. And of course, we're going to monitor blood glucose levels. We're going to monitor wounds for healing, look for signs of infection. And if we are giving it IV, it's going to be over 5 to 15 minutes. For this, there's a lot of client education that should go with the corticosteroids. We want to take it exactly as prescribed, because usually it's ordered as a dose pack with tapering doses that are going to gradually, you want to take a whole lot of them, 4, 5, 6 the first day, maybe 4 the second day. Anyway, it's gradually going to take down, and we won't taper down. And we want them to take these with food, because they are very irritating to the gastric mucosa. We want to make sure they're keeping follow-up visits and making sure they get their scheduled laboratory test. We need them to report any visual disturbances or GI distress, any sudden weight gain or swelling. If they have a sore throat, fever, or signs of infection, we want them to report that immediately. We want them to monitor their wounds, and if they're healing slowly, we want to know about that. They need to avoid crowds and persons known to have an infection, that even means colds, because remember their immunity is going to be down. They should not take aspirin or NSAIDs or any medication without consulting the healthcare provider. It's not for long-term use, and they should not be exposed to prolonged sunlight, because it can really cause terrible burns. It makes them more sensitive to the sunlight. We're going to stop here, and then the cannabinoids, we will probably finish up the last of the antiemetics in part 4.